Thank you very much for having me here today. It is a real pleasure. I'm going to start my talk today by telling you about a theory I heard, that we don't have mental health problems in Canada. What we have instead is a problem with mental health. What does this mean? It means that despite all of our anti-stigma campaigns, despite all of the progress that we've made in the treatment of mental illness over the last number of years, we still do not consider mental illnesses in the same league as physical illnesses. A Canadian survey found that 28% of Canadians with a mental health issue have disclosed this and told their employer. Sounds not bad, right? But twice that many, 56%, have disclosed when they had a physical health condition. You know, I was thinking about the impact of that statement, and as I was rehearsing my talk last night, my 11-year-old daughter said, "So, does that mean that if my teacher had cancer, she would tell the principal no problem? But if she had really bad depression and anxiety that was giving her trouble getting out of bed and getting to school, she wouldn't say a word?" I found that statement so impactful because it really brings us down to what the core issue is. And I would ask you, why is this? I think this is it. Imagine you're a marathon runner. You break your leg. It's in this nice blue cast for 6 weeks. And people can see your injury. They'll have sympathy for you. You will probably receive offers of help, assistance, support, accommodation, without even having to ask. And then, when you get your cast off, nobody's going to expect you to be back to 100% right away, much less run a marathon. Yet, we just don't think about mental illness the same way. As a psychiatrist, my patients often talk to me about feeling like they are the walking wounded, that no one can see what they're going through, so they don't receive automatically that sympathy, automatically those offers of support. And then furthermore, when they're feeling a little bit better, they're expected to be back to full steam right away and forget about accommodations over the long term. I run a program at Women's College Hospital, and several of the clinicians in that program are here today, where we focus on women with mental health issues around the reproductive life stages, so around the menstrual cycle, around menopause, and around the time of pregnancy. And I would say that nowhere is this problem that our society seems to have with mental health more evident than in the time around pregnancy, when about 20% of women suffer a significant mental health problem. Most of that would be depression, anxiety, but also more serious mental illnesses. Why do women have mental health problems around that time? Some women do have a sensitivity to the biological shifts in hormones that occur during pregnancy and then rapidly postpartum. But there are also major psychological, psychosocial changes that are happening around that time. So it's a high-risk time for mental illness, although I will tell you there are many, many women who struggle when they have no risk factors at all. And the thing is, there are treatments. For women with mild symptoms, they don't even need to come to the doctor. Peer support groups, exercise, nurse-led supportive interventions in the home, these will be enough for women with mild symptoms to have a remission of their symptoms. They'll do much better. Talk therapies, cognitive behavior therapy you might have heard of, interpersonal therapy. These are talk therapies that have tons and tons of evidence for solving depression and anxiety for people. When women are more ill with depression and anxiety, or when they have more serious illnesses like bipolar disorder and schizophrenia, medications are effective, as well as some other treatments. But here's the problem. Despite all of these effective treatments, there's clear evidence in Canada and around the world that only 1 in 5 women affected receive the help that they need. Why is this? Some of it is stigma and shame. Some of it is maybe not knowing that this is a real issue. Some of it is not knowing that there are actually treatments that could help. Some women worry about, coming and they're going to be told all you could do is take medications, and then they're worried about what that will be like for their child. But there's another issue too, and it's about access. We are a specialized program with lots of experience with women in pregnancy and postpartum and their mental health issues, but we don't exist everywhere. What if someone lives 200 kilometers away from us? We're a big country. But even if they live down the street, how easy do you think it would be to come for 12 consecutive sessions of psychotherapy at 2 o'clock every Wednesday? Please don't be late. Oh, but you can't exactly predict when the baby's going to sleep. And you can't exactly predict when the baby's going to need to eat. And you can't exactly predict when there's going to be a snowstorm or a traffic jam. I mean, you could count the ways that it becomes very difficult when you have a small baby, or even when you're pregnant, you're trying to get your hours in at work so that you can get your employment insurance for your leave. There are some really unique challenges in this population. And then it comes down to, well, now are you surprised that only 1 in 5 women get the help that they need? So what are we doing about it? At Women's College, over the last number of years, we've been working really, really hard to reimagine how we deliver care to women with mental illness around the time of pregnancy. We've been thoughtful about how we can better improve their experience when they come into the hospital, and we've also been very thoughtful about how we can reach these women for whom it is either so hard to come in, even if they live down the street, or who live very far away from specialized services. In hospital, we were very, very fortunate to receive a generous donation in order to be able to provide childcare for women when they came in, so that they can leave their children, their babies, and sometimes the older children who they're also taking care of at home, with an early childhood educator while they have their therapy. One of our research grants was focused on delivering couples treatment. And for many, many years, we'd wanted to deliver couples treatment. Men struggle too. When a mother's struggling, her partner's more likely to struggle. But people work, so how do you get them both in? Someone's got to make the money. We were able, through a generous research grant, to offer an evening time couples treatment along with the childcare alongside it. And guess what? People came. But there still are people who cannot make it into hospital. What you see up there is an online patient decision tool, which we have launched across Canada in a research study to help women, before they become pregnant or in early pregnancy, make decisions about what kind of treatments they could get. It tells them what depression in pregnancy is, what are the risk factors, and what are the different treatment options, and especially what are the implications of using or not using medication when you're pregnant. We have also been focusing on the postpartum. How do you find people if they're struggling, if they don't know that they're struggling, and they're at home, not exactly walking down to the doctor's office to self-identify and say, "Hi, excuse me, I have postpartum depression." No. So we've launched with the international community, actually, with our partners in the UK, the US, Denmark, and Australia, an app that women can download onto their phones and self-screen for postpartum depression. And we've programmed the app right now so that wherever a woman lives in Canada, if she screens positive, we're connecting her to resources and the services that are in her area. And for women in Ontario, we're also offering online virtual treatments. Our program developed Mother Matters, which is an online postpartum support group facilitated by our highly trained and highly experienced mental health therapists, where women can log in 24 hours a day to post, to discuss, and to have expert assistance as needed. We're also doing research trials to see whether delivering psychotherapy or psychiatric care virtually is just as good as in-person care. It always breaks my heart if I've, let's say, started someone on a medication And really, all I need to do is see them or speak to them for 5 minutes to check and make sure they're not having side effects, that everything's going okay. And when I hear that it took them an hour and a half, they woke their baby from their nap, they bundled their baby, the baby had an accident, they had to change the baby, then they had to get on the TTC to come downtown. I mean, we're talking about 3 hours for a 5-minute conversation. We shouldn't be doing that in our digital world. So we are really focused on leveraging in every way we can to be able to treat women in their homes. I think what the most amazing part of it has been for me, though, is that when we launch these research studies, we don't just give the intervention to everyone right away. So half of the women in the research study piece have to agree to wait so that they can be the control group, and then they'll get the intervention later. When we first launched Mother Matters as a research study, we recruited 100 women in a span of 3 to 4 weeks across Ontario, 50% of whom were agreeing to wait 12 weeks for treatment. That is an unbelievable and unacceptable health gap, that they would be willing to participate in a study where they had to wait that long to get actually a very common treatment. So as we move forward, we really have huge opportunities in this area to improve the care for women with mental illness across the lifespan. And what can you do? I would say it goes back to the beginning. It goes back to saying that by understanding that mental illness deserves the same care and consideration as a broken leg, as cancer, as heart disease, by understanding that these illnesses are real, by remembering that they're treatable, and by taking what you learned today to reduce that stigma and reduce that shame so that we can focus our energies on removing barriers to care and providing timely, high-quality care to all women with mental illness in our country. Thank you.